Hello everybody, I'll be talking about differences in retinal laser strategies in diabetic macular edema. These are my financial disclosures, none are relevant to this presentation. Laser photocoagulation has been around much before the anti-VEGF era, and there are studies which are demonstrating long-term benefit of laser in stabilizing diabetic macular edema. Subthreshold laser was introduced to avoid complications and side effects. However, the benefits of both threshold as well as subthreshold laser are limited in diabetic macular edema. But we all agree that there are cases where the laser is indicated. Our hypothesis is that the variability of laser treatment strategy is one of the causes for this variable study outcomes. Let's look at the variability of subthreshold laser parameters. There are 33 publications between 2010 and 2022, and you'll be surprised to know that there are 18 different parameter combinations. We believe that there are two cases where there is a lasting damage due to subthreshold laser. In one of the cases, there was a transient damage. There are very limited dose response studies for subthreshold laser, particularly for diabetic macular edema. These are the three studies, one from our group, one from Donati et al., and this is one more example I have put to show you the safety of various parameters in central serous. Let's look at these studies. In our study, we compared 5 to 15% duty cycle in diabetic macular edema, and we found that 15% duty cycle appeared to be more efficient in terms of visual acuity improvement as well as reducing the central retinal thickness. Donati et al. Compared fixed versus titrated protocol for diabetic macular edema, and they found no significant difference between two protocols. However, there was a trend towards the benefit with titrated protocol for diabetic macular edema. We believe that there is a more consolidated laser parameters for threshold lasers. The threshold laser is based on titration within a defined range. What about the planning strategy? Does the plan style really matters? Yes, it does. And this is a paper from DRCR which compared two laser photocoagulation techniques. One is modified ETDRS versus mild macular grid laser, and you can see there are significant differences between two laser strategies. So, are there differences in the ways physicians execute the modified ETDRS treatment? This is an interesting paper from Acta Ophthalmologica in 2013, which compared the ways the physician execute. These are some examples from the paper which shows that when the physicians made the plans based on stereoscopy, as shown in the top row, you can see the differences and there is a minimal overlap between the plans, and then these physicians planned based on OCT and there is an improvement in the plan. However, we understand that there is almost a 51% average overlap per operator, and there is a significant difference between the laser spot count, that is around 6 to 11 fold. With the help of digital planning options now that we have available, such as Navigate, we can improve this planning as well as we can quantify the differences. The Navigate app is available on any web browser and on iPad. It allows the planning of single spots or pattern in line with currently available parameters on subthreshold laser system. It imports all kinds of images possible. Therefore, you can overlap or use this multimodal imaging while you're planning the laser treatment. This is one of our example where we are showing that if you can make a plan based only on the color photographs as shown in the on the left image, and you can see when you overlap with fluorescein angiography and when you overlap with OCT thickness map, and you can clearly see the differences between this laser planning and this is an example which confirms the findings from the previous publications. This is one of the example where three different experts made the plan based on fluorescein angiography, and you can here see that there is a significant difference between the planning for three experts. Right now, we are investigating the differences between the plans of different experts to further understand what the optimal plan is and to minimize the variability of laser results. With the help of Navigate or Navilas Laser, we are able to reduce the risk of variability by integrating all the imaging information with Navilas, as you can see in this video, where the operator is utilizing OCT volumetric thickness map in deciding his treatment plan. As we saw that there are still no protocols for subthreshold laser, in the hope of establishing subthreshold laser protocols and treatment guidelines, we started a society called SOLS, Subthreshold Ophthalmic Laser Society. These are the founding members for the society, and we have an executive committee in which we have members from all over the world who have a lot of experience with subthreshold laser. Working with these experts, we established subthreshold laser guidelines for retinal diseases, and this paper was recently published in journal Eye. For diabetic macular edema, SOLS experts believe the subthreshold laser is applicable in both center involving and non-center involving macular edema in conjunction with or without anti-VEGF therapy. We recommend 5% duty cycle with 200 millisecond pulse duration and 150 to 200 micron spot size with no spacing between laser spots using integrated pattern system. We recommend titration with 50% of threshold power, and the thresholding is achieved with subthreshold laser. We recommend subthreshold laser application to edematous area. However, we do not mandate focal treatment of microaneurysm. SOLS experts believe transfoveal subthreshold laser treatment is safe after reconfirming the laser settings, which should be for subthreshold laser. We do not recommend any specific structural imaging studies to evaluate laser spots. However, autofluorescence on OCT could be carefully evaluated during follow-up visits for any laser scars. Follow-up evaluation at 6 to 8 weeks after subthreshold laser application. However, repeat subthreshold laser is suggested after 2 to 3 months of initial application in case of poor response. To make note that these are subthreshold laser guidelines, we are not recommending diabetic macular edema management, so leave the adjunctive treatment therapies such as anti-VEGF or steroid to the physician discretion, and this would help us to get better patient care for our patients. I would recommend you all to go through these laser guidelines and start applying in your clinical practice and give us your feedback, and this is a learning curve for all of us. With this, I would like to conclude saying that there is a large variability in parameter selection for subthreshold laser. Previous studies and some of the case examples which I shared demonstrate a large differences in planning style of different experts. There is a variability of treatment planning which needs to be quantified. This may have an impact on repeatability and reliability of laser treatment. We are yet to study the variability and its influencing factors. However, there is definitely a need for discussion about cases of variable planning. Thank you so much for your attention.